Thank you guys for coming to have fun with me today. This is a part of a program that we are doing at Hospice of Marion County, and for that matter, for CCPC as well. And we have recognized that we need to learn every single day. We're going to be learning about how we are different, but we are the same. And how this is important and tied up with what we do in Hospice of Marion County, which is providing the excellent care to every single person that we enter in contact with. So we're going to call this culturally competent patient care, because that's what we mostly do. And we had objectives. We need to understand the challenges and benefit of diversity. We're trying to relate this diversity to organizational values, and we say that excellent care at end of life. So that's what we do. We are going to identify what kind of problems we may bring while doing that based on where we're coming from. And we're going to develop a specific skills. Okay? So we're going to start with some general concept, and then we're going to go for what it matters to us, which is patient care, and we'll get there. When we're trying to push changes or implement changes, there's always the question is what we're going to be changing here. So we are trying to change our awareness. So if we make ourselves aware of an issue, we may attempt to solve the issue. We are going to be aware of we're going to try to change our attitudes about that issue, as well as our resultant behavior. So we're going to have to change what we do and how we do it. We're going to define certain concepts, and here we are. Culture is every single aspect of human beings. Whatever we do, it becomes culture. How we talk, how we dress up, how we move, how we congregate. Every single activity of a human being becomes part of our culture. And for that matter, for every single group. If you sign up in a group because you're in a group in church, or because you're in the Rotary, or because you're in the hockey club, you're expected to dress some way, to behave somehow, to learn a slang for that. And so that gives you the opportunity to belong, to be protected from other people. I don't know anything about hockey. Herb does. So he comes to me talking about that. He knows, he feels comfortable in the group, but I'm completely clueless. If I want to become part of the group, I'm going to have to start going with him to the games. He starts having to teach me, so I may be integrated in that. And that's what we're talking about culture. So every single group that we belong to is going to have certain rules, certain characteristics, and that's what defines a group. In the healthcare, we are a specific culture. We talk about completely different language. We behave in a completely different way. Not everybody is walking around naked with a little gown on top of them. That we only do that at the hospital in this society. We talk a completely different language. We talk about a technical language, and then we interact with somebody else that doesn't belong to that group. It becomes an interface, and it may represent problems for that other person and for us as well. So because our group is providing us with safety, security, and give us meaning of our life, we feel comfortable in that group that we chose to be, because nobody forced me to become a nurse, a doctor, a social worker, a chaplain, CNA. We chose to do that. It gives us a specific environment. It represents a specific economy. We have a technology to do that. It becomes kind of a religion, because we make promises and we follow certain rules on that. And it's represented mostly by a specific language. So when I follow the culture of the group that I belong, I'm expecting to survive that group. As long as I'm going by those rules, I should be accepted and provided with safety. It will give me meaning for my life, and we share something. And there's nothing more comforting for human beings than being in a place where we're sharing something in common. So that would make us socially, morally, and legally integrated in a structure. Having said that, whenever we mingle, like the M&Ms in the bag, Each one of us is going to bring our own culture when we become part of this other group. So wherever I'm coming from, whatever I think, believe, cook, talk, and the way I dressed up is going to become now part of this group that we call healthcare. And that's going to be affecting the way we do things at all levels. The groups that we're going to be talking about specifically about cultural diversity are going to be represented by race, ethnicity, gender or gender identity, because now things are changing, age, religious affiliation, and sexual orientation. Why are we talking about this? Why, I brought you over here and we're going to talk at 3 p.m. eating M&Ms about this issue, because it's important, okay? Because we need to know about this, because these issues may become part of our patient care and they may be more comfortable for other people than others. So if we don't bring these issues up, we don't get to discuss this and we don't get to become more knowledgeable, more comfortable in these issues and giving better care to the patients and among ourselves. So it's relevant. It's going to be giving us respect from who we are and what are we doing and how we are doing things. And it's a responsive situation. So we have identified an issue, now we had to do something about it. We have identified that we need to become more cultural knowledgeable because we need to provide care for our patients in the best way possible. So when we talk about diversity, we as a group, Hospice of Marion County, we are representing our community. So if you look around, we are a representation, a sample of what Marion County community looks like. How we looked like, how we dressed up, what churches we're attending, our socioeconomic level, our educational level, all this is represented here. So we are a representation of the community that is here. But we also have our personalities. Each one of us has a completely totally different personality, and we bring that to our work. So that's also part of that different group. We have cultural references because we're coming from different places. And each one of those places we're coming from will have a specific culture that we bring into the culture of Hospice of Marion County. We have physical abilities. You cannot ask Charlene to pick up something from the top of the cupboard. You're going to have to ask me to do that because you're going to have a hard time doing that, okay? But you're not going to ask me to place a Foley catheter because she does a much better job than me, at least in females. We bring into that our personal experiences as well. When we talk about inclusion, it's because we need to include every single one of us in every single activity that we do. So I cannot say we're going to have coffee and cake for the boys on the right side and a spa treatment for the girls on the left side. Because Warren is going to complain that he wants coffee and a spa treatment. And I had to respect that. So we have to include among ourselves, whatever decision we're doing, we have to include everybody in there. It shows tolerance, okay? And it shows that I am elevating each one of you to the level that you need to be treating in a respectful manner. However, whenever we're doing that, we bring biases to it. Whenever I am told we are admitting a patient who is 50 years old, what is the first reaction that we have? Oh my God, he's young, right? Oh, my sweet Lord. So it's not okay for him to die. But when I bring in a 100-year-old, so it's okay for the 100-year-old die, right? So I'm sure you have your patients and say, I'm sorry, it's okay for you to die because you're 106. So go ahead, chop, chop, move it along. That is the bias that we bring over, okay? And we have to be aware of that bias in every single characteristic, because if I identify that bias, I can do something about it. I can be aware of that, avoid that bias is going to affect the way I am treating that patient, their cultural group, which will be the family, the church, the facility we're taking care of, and giving the excellent care that the 100-year-old deserves and the 50-year-old deserve. Okay? So that's called ageism. We have patients, and the record says, patient with advanced age. That patient was admitted to the hospital 5 years ago when she was 89, and now she is finally to hospice care, and she was called old 5 years ago, what is it today? Older. But she's still not okay with dying. Okay, because for her it doesn't matter. Every single day is a special day for her, no matter if she's 5 years old or 500 years old, and we're here to take care of all of them no matter what. I bring my biases all the time. If I go to Aldi, I'm expecting the fruit is not as good as if I go to fresh supermarket. Just because there's a very good marketing department out there selling me the idea that fresh supermarket is much better than everybody else. So that's the bias I'm going to. When I go to Aldi's, I find very fine fruit there, which is much cheaper, and I do my job. Okay? So those are the kind of information that we bring with us when we are doing our care, our patient care. When we're going to go and see a patient, the first thing we report is age, race, where the patient lives at home, what are the medical conditions of the patient, and the social history of the patient. Just that, it brings a bunch of biases to that presentation. I was just talking to somebody here, and that person was concerned because a specific other person was going to the patient's home at nighttime. One of us didn't know that all of us go to patients' homes at any given time, 7 days a week, 24 hours a day. And that we take consideration in our safety, and that is what we do. But that is a very good question. What happened with us when we go into an unsafe environment? Well, we take provision. We present that in our report. We accompany ourselves. So the nurse will call the chaplain and say, hey, come with me because I don't feel like here. So the chaplain will say, hey, bring the social worker, the more the merrier. Okay? So those are the things, those are the biases that we're bringing into our interactions. And they may be absolutely okay because it keeps us safe. But if we let that go a little bit further, it may become discriminating. I'm not going to go there because that is an unsafe area. So that person that requires our service, it will not be provided with care just because, in my opinion, that is an unsafe area to go. And that's not what we're here for. We're here to provide care to everybody in the best way possible for everybody. When that discrimination becomes prejudice, I'm not going to be able to say the word, a prejudice, whatever. When this word becomes discriminatory, okay, we bring race as an attitude to become biased in our interaction with each other. And they have been called all sort of terms. Racial discrimination, racialism, racial prejudice, and bigotry, xenophobia, chauvinism, bigotry, bias, intolerance. Probably the one that I hate the most is this one here, intolerance. When we don't tolerate each other, we get into very complicated relationships. And once we identify that, we need to do something about it. This is a concept that I don't know if we are aware of. This is a difference. Race is different than ethnicity. And when we talk about race, it's what the person looks like, not necessarily define what the ethnicity they identify with. Because if you were to see my mother, she looks probably like Dr. Thomas' mom, very fair skin, blue eyes, and she speaks no word of English. Okay? So you may assume if you see her walking in Walmart, you may come to her speaking in English to her because you have no clue she's Hispanic. But she's whitey, kind of pinkish, Hispanic. Okay? And that's why these two terms don't necessarily correlate and not necessarily are equal. And now we have different locations in our forms, in the medical records, in the application form for our jobs, to call race and ethnicity. I used to do this thing that whenever I fill this form, because it's something new for me, in my culture we don't pay attention to these things, but here it's important. So when I came over here, I started this business of I am white because that's sort of kind of my skin color, but I'm Czech, American, Native American, Hispanic, and white as my ethnicity. And then I started to figure it out. I have scientific proof for this kind of odd behavior. So when I did my genetic pool, thinking that I was going to be only Spanish, so mean from descendant from Spain, because that's what I've been told all my life, that everybody down in South America come from Spain, at least in Venezuela. I figured out that the 50% that come from Europe is actually a share between Spain and Portugal. I have never been in Portugal. I have no idea where that came from, but that is there in my genetic pool. Okay? So now I had to add into that. Now I had to start speaking some Portuguese somehow, and I'm probably going to be going to Ipanema more often. I also have the 25% that I'm always checking off, because down south we have mixed very much. So each one of us, regardless of the color of our skin, we have some Native American composition. And it specifically says that it's Venezuelan. So gee, I got it. And here I have my 2% of Congolese. So the way the history goes, Portuguese people went down to Africa, pick up a bunch of people, make them a slave, and made them cross over. So in my pool, I have some of that as well. So I have a slave blood as well. So whenever I hear some kind of drums, I start checking my booty, okay? Because that's how I do it. I'm very proud of that. So when I have to define myself, I probably will go with the race, white, I will check each one of them, but my ethnicity is going to be Hispanic. Now, in the Hispanic group, we have definitions. I just went to Lowe's 2 days ago, and the guy, Carlos, tells me, as soon as I saw Carlos start talking to him in Spanish, of course, when he say, I think I feel a Venezuelan accent. And my answer to him was, I think I feel a Puerto Rican accent. So among the Hispanics, there are some other groups. And sometimes they fight with each other, or we fight with each other. Sometimes we dance with each other. But there are different groups as well. So they kind of be clumped all together in the same way that we cannot clump all together Anglo-American or African-American. But for the sake of studying groups, we're going to define them and divide them somehow, okay? So when we're going to be cultural competent healthcare providers, we have to assume, we have to learn that culture is in part portion of how our patients behave, part of how we behave with the patients, what is going to determine their prognosis, how they're going to be taking the care that we are providing to them. We have to be aware of that to learn what attitudes we have about it and how our behavior changes. From the get-go, I have a very hard time understanding why somebody is going to become a substance abuser. And a lot of people share that with me. Even as a psychiatrist, understanding that a substance abuse is a disease of the brain where the brain cannot control that, I still have my internal bias because this 30 years old has been drinking all his life and now he's dying, while this 100 years old has lived that much. What do? I am aware of that, so when I'm going to take care of the 30-year-old alcoholic, I am aware of my bias, and I'm going to make sure that that is in front page for me so I can treat the patient the best way possible without letting that bias interfere in that. So I cannot accept that a person that is an opioid dependent, and because they have IV drug user, now I'm not going to treat their pain in the right way, now they have pain, just because I got the history in there. So I had to bring my bias to my conscious level. So in that way, I can provide care in the best way possible for this person, because this person is going to die just once. And he came to me, or she came to me, for me to take care of him or her. So I need to be doing my best, because we don't have do-overs in hospice. We only die once, and if we do it wrong, it's going to stay forever with that group, the family group. So the 4C of culture is when we intervene with a patient, when we interact with a patient, understanding they're coming from a different group, okay, meaning that they're coming from somewhere that they have no knowledge of healthcare or may have some knowledge in healthcare. We had to find out where the patient is at for us to be becoming part of that care. We need to find out what the patient is thinking is going on with them so we can help them to accept and modify their behavior, okay? So these are the the 4 C's that cultural-based care is recommending. When we ask the patient, what is wrong with you, we want to know what is their idea of what is wrong with them. Most of our patients don't even know what's wrong with them. Somebody sent me to hospice. My doctor told me they couldn't do anything else for them, so that's what I'm here for. Because you kill people, and that's what I'm here for. Okay, so that's what the seed they're coming with. That's what the concept of what hospice is about. And it's our job, based on where they're coming from, to identify that, modify that, and help them with that knowledge. So what do you call your problem today? A person can say, I have sugar diabetes, right? They say that. Or somebody else can say, I have a type 2 diabetes mellitus without complications. They say exactly the same thing in a completely two different languages. Same English, or sort of kind of English. What do you think is wrong with you? Well, I have cancer, but the doctors gave up on me. So now it's your turn to take care of me because there's nothing else to do. How many times we hear that? Okay? Too many to count. What do you think caused the problem? Oh, that was the damn doctor. They didn't pick up the cancer at the right time, so that's why I'm dying today. And when you get the social history, they've been smoking all their life. They have been, doing all sorts of things, drinking every single day, but they don't take responsibility of that because somebody did this to them. And we are part of that group because we're part of the healthcare system, so we're at fault with that. So how easy is it going to be for that person to trust us that we have been letting them down all their life? We have to remember those. It's very difficult to trust somebody. A, we're telling them they're going to die. B, trust me, I know how to do this. C, you're going to take that medication because I know better. Okay? It's not an easy deal. What have you done until now for this? So you tell me you had cancer, and what have you tried? I tried everything. I went to Mayo Clinic. I went to a cancer center of America. They gave me chemo, radiation, surgery. And we're going to tell them they're going to get out of the hospital. We have all these gadgets, giving them support, and we're going to be moving to Legacy House when they have a beautiful room with no monitor whatsoever around. So how are you going to know that I'm sick? I'm coming for 3 months in the ICU when every time my heart rate goes 115, somebody comes running to the room. And you're going to leave me alone in that room now with a TV and a remote control? That is a source of a lot of anxiety. That's where the patient is coming from. And we're expecting them to accept our care because we know better. What concerns you? What are your concerns? The 50-year-old that is dying, and we feel sorry for that, he's concerned about, or she's concerned about, that who is going to provide with my family? We just had a patient. 56 years old, cancer, I don't remember where it is, and until Friday she was working because she has a 19-year-old at home that depends economically from her. The 100-year-old is concerned because her Part B needs to pay for her medications. Those are two different concerns, but they are still valid, for each one of them has exactly the same weight, and they want to be heard, and we want to hear them the same way. We're going to modify our behavior. We're going to have to do different things about it, but still, that's what they're here for, and that's what we're here for them. So what we're going to do, we're going to do a bunch of things. One of them, you're going to eat your M&Ms, and that's how you're going to remember. Anywhere that you are, the back of M&M is the group. And whatever is inside, each one of them, probably more or less the same shape. We are more rounded than others. When we are caught, we all bleed red. Dr. Thoman can tell you that. He had caught a lot of people in this world. And blood is red for everybody. Okay? But outside, we are different colors. And we probably taste the same. And that's who we are, and that's what our patients look like. So some of those activities are going to be, we're going to be having a food festival where you guys are going to feed me whatever you think represents your culture. Because even if you are from the USA, some of us are going from the north, we're some from the south, from the right, from the left, west, and east, and we tend to eat different ways. So we're going to see, we're going to guess where the food is coming from. So we can do fun things with this concept. We're also going to show our patients our cultural commitment. So we're going to ask the specific question, what kind of food you like to eat? And we do that when the patient goes to their houses. But I'm sorry, if you don't like tomato soup, it's the one that we have. What can I do about that if you don't like tomato soup? You don't like tomato soup because you're allergic to that, because you have something against red, or what is wrong with that? Okay, we have to acknowledge that. Sometimes we kind of go all the way there, like the patient that went to Legacy House and told them, Dr. Lozada said that I could eat here whatever it feels like. And the family show up with something like 20 pounds of lobster, expecting the chef to prepare it for her. So I don't know if Kim was at that time in Legacy House, but I got a call asking what on earth I had told the family when they were in the hospital. So and my question was, what time is the lobster going to be ready? When we are in the IDG, this is something that we need to discuss. Where is the patient coming from? What is the patient expecting from us? I ask all the time, what flavor is the patient? Okay? Because that helps me to sort out how I'm going to be providing them with the care, how I'm going to be explaining medications to them, where do I think the patient wants to die. Some of us like to die in the hospital, some of us like to die at home, some of us like to go to IPU. That is culturally based. And culturally, you can call it anything. Baptist, Catholic, Jew, fat, skinny, tall, short. Depending where they're coming from or what they're bringing into the table, I need to be sensitive to that so I can provide the care they want. We can have bulletins boards talking about things like, where's the best bread in the whole entire world? Who makes the best chocolate cake in the whole entire world? Beverly is not here, but that's the best chocolate cake they've tried. Or at least my son thinks so. This is what this motivation is about. This is not about, this is about making difficult subjects the easiest way possible so we can learn to live in the same M&M bag. And have fun, because at the end is all that matters. When we're dead, gone. Either when they make us barbecue or they put us on there to feed the worms. So while we're here, might as well have fun with something. These are some clinical tools that we can get. There's central place that you can go, and it helps. I have a patient we just had a patient from South Korea. Actually, I had 2 patients from South Korea. I don't know anything about what they eat. When she asked me that, when she told me that when they are sick, they make chicken soup. My Hispanic chicken soup has onion, garlic, potatoes, calabaza, being pumpkin, chicken, and rice. Her rice soup is rice and water. And that's all she will take if she felt ill. So she was not eating, period. And I asked her, what do you eat when you feel ill? We make rice soup. How you make it? Because I'm sure my rice soup doesn't look like your rice soup. And with that recipe she gave me, I went to the kitchen, and Monica very, very, very immediately made the rice soup for her. That brought her back home. Okay, so the person that was not eating now is eating some. And it has nothing to do with mirtazapine that we put the patient on. It had to do with the fact that she identified with that. When you are sick, you like to eat macaroni and cheese. That's called comfort food, right? For me, comfort food is my mom's soup. So these are resources for you guys. We had to show them that we're committed to this. We need to use the language that the patient identified with. Because if you're ill, if you're blind, if you're old, you don't want to be struggling with anything else. So we don't want to add one more to the patients. Okay? So we want to make life easier for them. And if you come to a place and say, I don't read any English, how are we going to do these 30 pages of consent that I have? I might as well help the person to do it. Never mind, the Medicare is requiring that. So by Medicare standards, we have to have language-specific form for the patient that's coming over. Even though we're going to talk about groups, we have to assume that they have something in common, but any other group and any human being are going to have differences. Okay? If we talk about the USA group, as we talk about, people from the north have a different accent from the people from the south. They will eat different food. They will dress differently. People from the west, they act differently. They talk differently. They are different than the people from the east. So when I clump these groups, I want you to understand that maybe you to help to understand this specific group, but we also had to accept differences among them, okay? So let's go. What can cause conflict when we're taking care of patients that belong to different groups? Their language, their diet, their cultural beliefs, their religious beliefs and practices. And some of those are more obvious than other, okay? If I go there and find the patient has tattoos from here to here, and they have a purple hair, that doesn't look like something like me, even if we both are Hispanic, because I don't see myself with a purple hair. Derek may ask me to do that. I say, it doesn't go with me, okay? But there's some other things that may be not that obvious, how we communicate, what values we have, what ethic we apply to that, because it may be different. And it's being different doesn't mean it's going to be better or worse. The fact that we are in a different group doesn't mean that mine is better than yours just because I am here and you are there. That means you're just different. There are different